Hello, everybody, and welcome to the protocol update for the New York City REMAC protocol changes that take effect January 1st, 2022. My name is Morty Lax. I'm a New York State CIC and chair of the New York City REMSCO Training and Education Committee. You're going to hear from various committee members who are all educators in New York City, and they're going to be discussing the protocol changes with you. Over the past year, the protocol committee and REMAC have all met and discussed numerous protocols that we will be talking with you about during this update. This protocol update will be divided into modules that will end in a self-assessment. Those are all going to help you to identify key areas and make sure that each module served its purpose for you. At the conclusion of the update, there will be an exam. When you pass the exam, a certificate of completion will be generated that you can share with your agencies to evidence completion of the protocol update. I'd like to begin with a few thank yous. Number one, thanks to all the committee members that have given of their time to record the various segments in this update and make sure that this information is delivered to you in as appropriate manner as possible. Number two, or maybe this also should have been number one, or equally with the committee members, I should say, thank you to the Fire Department Bureau of Training, their dedicated members for their collaboration and the hard work that they put in as these resources, the presentation have been developed by them with some modifications that we have applied to make this more applicable to be delivered online. So thank you very much to everybody that was involved in every part of this process. The protocol changes that you're going to be seeing throughout this presentation are really a summary of a number of things. American Heart Association changes. So the protocols have been brought up to speed to current AHA guidelines, as well as bringing everything up to date with the recommendations of REMAC with the best medical practices, evidence-based medical practices today. It is recommended as you go through this update that you have the protocols themselves side by side along with you so that you can view them as we go through the changes, although the slides themselves will be showing you the individual changes as they appear in the protocols, but you'll be able to see them full picture. Additionally, the REMAC advisory that is being sent out for this, which you should have already received, and if not, can be accessed online on New York City REMSCO's website, will have a bulleted list of the changes as well. So those will help you and guide you through this as well. So some of the things that you're going to see here, the general pain management protocol. So pain management in the past was applicable to various protocols in some places, as well as a isolated extremity injury protocol. You're going to see here that that has been completely changed, and there's a general pain management protocol that applies to everything. Credit over there goes to, again, the Bureau of Training, the Fire Department, and Dr. Ben Zabar, who recorded this video and did a great job delivering that information, which you will see later in the presentation. There is some general discussion regarding pediatrics and some changes over there as well. You're going to be hearing about the New York City SLAMS stroke assessment yet again. While there were some changes to the protocol, which will include some medication and quite importantly, I should say, an increase of the time for last known well to delivery of the patient to a LVO center in an LVO stroke of 24 hours. You're going to be hearing some reminders about some issues that our Quality Assurance Committee has been addressing lately. And so that is what we have regarding SLAMs. So there is a new definitions section, which will grow over time. There is a new section for specialty care facility transport procedures. And as you see here on this slide, non-invasive capnography, oral gastric tube, a transfer of care section, and GOP was actually shortened to 25 pages. Beginning with the first definition here, excited delirium. Due to today's environment in general and the fact that there are many definitions that you may have heard floating around regarding excited delirium, it is really important that we understand what this protocol applies to. And in order to understand that, we really need to understand the definition that we are going by. And this is the true definition today of excited delirium. Right? It is a behavioral syndrome that manifests with a certain number of physical characteristics that you see here in the slide in front of you, including the behavior of the patient, violent or bizarre, insensitivity to pain, elevated body temperature, abnormal strength. These are things that you will often see with stimulant use. Many of you have seen these in the field before, especially an example would be patients that have taken K2. Those are the type of patients that this applies to, not the regular behavioral emergency that is acting perhaps a little bit agitated. That is quite different than the definition of excited delirium. Advanced airway management. So pulse oximetry in this evolution of the protocols is now mandatory for both ALS and BLS. For EMTs, up until now, it was an option. It is now mandatory for all. Non-invasive capnography has come up as an option. I think many medics will find that as a welcome addition and is good practice in many types of patients. And advanced airway management, here is another definition for you, if you will, refers to endotracheal intubation or the use of a supraglottic airway. When it comes to pediatric advanced airway management, in the past, we used to grab and go. As you will see in the discussion on pediatric patients later in these protocols, we're actually going to be staying a little bit longer and treating the patients to begin with, which when we talk about adults should drive us in adults towards advanced airway interventions. In pediatrics, that is still not necessary as long as you can effectively ventilate the patients with a bag valve mask. In those cases, this can be used as a reasonable alternative. If you are intubating pediatric patients, in the past, this was done with an uncuffed endotracheal tube. We are now doing that with a cuffed endotracheal tube. And orogastric tubes have been added to these protocols as well, and that will help reduce gastric distension and help with better ventilation of the patients and reduce potential for aspiration. Intravascular access and medication administration. So when it comes to adult and pediatric patients, specifically those that are in shock, not in general protocols, but for those that are in shock, there was always debate in the past on what the definition of 2 attempts were. The protocols are pretty clear that it's 2 attempts total. However, in shock, we really want to make that extra effort to make sure that we get vascular access, and that now includes 2 attempts at IV and 2 attempts at IO, not 2 attempts total, as it is in all the other protocols outside of shock. So pediatric size estimation. So pediatric length-based devices that we've used up until now as adjuncts to help us determine everything regarding wherever it is that the patient falls into on the scale of the device we're using. Moving forward, we are only going to be using these to help estimate the weight, height of the patient and the size of the equipment. When it comes to dosing of these patients, we're not using these devices anymore, such as the Braswell tape. We're going to be using the specific REMAC protocol pertaining to that emergency for specific medication dosing. So again, pediatric size estimation and the size of equipment used is the only thing that we're using these devices for moving forward. Transfer of care between ALS and BLS providers. So this is a new protocol that I think everybody in the field now is going to find beneficial and helpful when interacting among BLS and ALS crews on dual dispatch calls. So when both ALS and BLS are providing care for the same patient, and ALS is not necessary, as long as the patients meet the following criteria, ALS can transfer care to BLS providers. Right. So here is a bulleted list for you. Hemodynamically stable patients, patients that are able to follow simple commands, which means they're mentating well, a blood glucose level of above 60, so they're not hypoglycemic, patients that have not received any ALS medications or treatments, those that are not expected to require any ALS intervention, and no reports of acute coronary syndrome, ACS, either ongoing or those in the past 24 hours. So these are patients who might still require intervention now or have the potential to require intervention during transport. Those are patients that we want to make sure have the best, highest level of care possible throughout their care. Additionally, when ALS and BLS are providing care for the same patient and the patient requires the ALS unit for transport, it is the recommendation now, it is the protocol now, that both units transport the patient if the patient has any of the conditions listed below. Either placement of an advanced airway or assisted ventilation. So these are airway issues. We're talking about the highest acuity, really sickest patients, a cardiac arrest or potential or concern for deterioration in the patient's condition, or the paramedic feels that they need the extra assistance during transport. So we really want to set everybody up for success here, set the patient and all the providers involved for the best success, for a good outcome or the best possible outcome for these patients by having the right amount of providers and the right sets of hands on all these calls.
The cardiac arrest protocols have been updated to encompass all forms of adult cardiac arrest rather than separate protocols like before. And some things have been changed a little bit around. So we'll take a look at those as we go on. Epinephrine administration is to be done immediately following intravascular access, and lidocaine, our old favorite, has been added back to be an option for VFib and pulseless VT. Lidocaine is a sodium channel blocker, raises the fibrillation threshold, and is a useful alternative when amiodarone is not available. During pregnancy, however, amiodarone is probably your first choice during cardiac arrest. Medical control options have been streamlined substantially. You should only call medical control for suspected tricyclic overdoses, salicylate toxicities, or hyperkalemia, and if you need to administer sodium bicarb. Transport is no longer the highest priority in pediatric cardiac arrest. There is much more emphasis on establishing advanced life procedures and getting those things on board on scene, as you will see when you review the protocol. One of the main differences that we'll see this year is in pediatric cardiac arrest, where transport is no longer the highest priority. More current thinking is to establish advanced life support procedures on scene, get some medication and treatments on board, and then transport the patient. But you'll see in the combined protocols that the differences between the approach for adult non-traumatic arrest and pediatric non-traumatic arrest are essentially the same. So that makes the process a little bit easier for all of us to adapt to. You should familiarize yourself with the charts that accompany the protocols as far as what procedures need to be done. And there is, of course, a comparison between what we normally do for the adults and what we normally do for pediatrics. One of the things that you will see throughout our discussion today is that many drugs are now being given on a weight-based basis, which of course is something fairly standard for us when treating pediatric cardiac arrest. Remember also that lidocaine or amiodarone can be used in all age groups during non-traumatic cardiac arrest. In treating bradycardia, there are a few changes. Certainly for paramedics, administering epinephrine is a standard approach. However, now instead of giving a standard dose, we are emphasizing again the weight-based dose. And in cases where there may be a consideration for decreased vagal tone or primary AV block, atropine on a weight-based dose may also be given. In respiratory failure, some changes come about for EMTs in that the implementation of CPAP should come before the assistance with nitroglycerin. For paramedics, one change is that in the treatment of pulmonary edema, the administration of nitroglycerin is tied to a systolic blood pressure greater than 120 millimeters of mercury, which is a change from the prior 100. Some key points to remember in treating pediatric respiratory failure. Bradycardia is an ominous sign that cardiac arrest may be imminent. Blow by oxygen in treating respiratory failure is an inadequate means of delivering oxygenation, and ventilation is a reasonable alternative to intubation. So some small changes, but significant ones there. Opiate overdose has been taken out of the altered mental state protocol and is now a separate protocol which will be dealt with elsewhere in this presentation. For other types of overdose or altered mental state, there is no longer a maximum dose of dextrose or glucagon. In cases of anaphylaxis, for EMTs, Atrovent or ipratropium bromide is now within the BLS scope of practice, and 3 doses of albuterol mixed with 3 doses of Atrovent may be administered. Paramedics now have the option of administering crystalloid fluids by the 20 milliliters per kilogram standard and may give 3 additional doses of albuterol on standing orders. In the treatment of anaphylaxis, paramedics will continue to give epinephrine as needed on a weight-based dosing. 3 doses are now on standing orders of epinephrine, which can be given every 3 to 5 minutes. Now, another consideration. If patients have a strong history of anaphylaxis and have an exposure to an allergen which previously might have given them respiratory distress, hypoperfusion, or a rash, we should consider treating it as anaphylaxis with a high index of suspicion. Dexamethasone is now an option, again, as is methylprednisolone. However, the number of routes by which we could administer the drug has now been increased, and dexamethasone can now be given either IM or PO, and methylprednisolone can also be given IM. That's a bit of a change. In excited delirium, we have a number of options for delivering midazolam. We can either give it IM or IN, and continue, of course, to give it IV as in the past. Again, weight-based doses. The pediatric doses are half of the adult doses. No pediatric diazepam should be given. In treatment of excited delirium, we know that we're going to be giving medications on a weight-based dose. But of course, trying to find out somebody's weight in the field is not an easy proposition. So of course, we have to approximate. But there is a formula we can use which will bring us closer to the weight that we want to get for administration. For men, 50 plus 2.3 times the patient's height in inches over 5 feet. So for example, if someone is 6 feet tall, take the number of inches between 5 feet and 6 feet and multiply that by the formula. So that would be a difference of 12 inches. 50 plus 2.3 times 12 would give us an approximate weight of 78 kilograms. So again, 50 plus 2.3 times the patient's height in inches over 5 feet. I know you're probably zoning out on it. You might have to work with that one a little bit, but it's there for you. Likewise, for females in kilograms, 45.5 plus 2.3 times the patient's height in inches over 5 feet. So if you have a female patient who's approximately 5 feet 2 inches tall, 45.5 plus 2.3 times 2 would give you 50 kilograms. I know math was not your thing, but it's important in terms of calculating the dose.
For the protocol for acute coronary syndrome, suspected myocardial infarction, chest pain, the changes for 2022 are that when giving nitro, the systolic blood pressure has now changed to 120 instead of a minimum of 100. In addition, some of the key points are that if available, fentanyl is preferred over morphine for pain management. So on the right-hand side of your screen, you can see the change exactly is that it is increased the minimal systolic blood pressure for nitro to 120 versus the 100. Now EMT and paramedic have the same vital signs, and fentanyl is preferred over morphine. As we move on into atrial fibrillation and atrial flutter, we highlighted unstable, but because the protocol is now changed, or the formatting is changed, to have a specific area for stable and a specific area for treatment for unstable. This treatment, there is no difference. So there's no difference in the treatment, it's just a change in the formatting. Since we have parsed out stable, the addition there is saying that you can contact online medical control for medication administration options. So the formatting split between stable and unstable for two different sections, and medical control options are formatted differently. Also, the option to treat stable by contacting online medical control. And medical control options, we added fluids. Fluids are added, that crystalloid fluids of 10 milliliters per kilogram IV has been added to the protocol. As we move into bradycardia dysrhythmias for adults, again, formatted differently, unstable and stable are two different sections. And now the change is atropine is now 1 milligram, which matches up with and reflects the American Heart Association 2020 guidelines as opposed to 0.5 milligrams. So the change for 2022 is 1 milligram. We're also adding in 12-lead EKG. So evaluating, performing, and recording a 12-lead EKG as an addition. And then, of course, transcutaneous pacing. So the way the protocol reads for stable bradycardia dysrhythmias is that you're contacting medical control for any kind of options, medication options. Now we have some additional medical control options that we'll talk about in just a second, but just to review, the formatting is different. Again, split stable and unstable into two different sections. The option to treat stable by contacting online medical control. Atropine dosing has changed from 0.5 milligrams to 1 milligram. Addition of doing a 12 lead. And then the medical control options, there's an addition of an epi drip, and then the change in dosage for dopamine drip. So let's talk about that a little bit more in detail. Medical control options, which you can call for stable or unstable. Medical control options, administering dopamine at 5 micrograms per kilogram per minute, and with a maximum dose of 20 micrograms per kilogram per minute. That is a change from 2 micrograms per kilogram per minute with a max dose of 10. For 2022, medical control options, adding in an epi drip. So epinephrine 2 micrograms per minute with a max dosage of 10 micrograms per minute, and you're titrating every 3 to 5 minutes. And this is completely a new addition. So there was no option for an epi drip before, and now there is.
So just to conclude the bradycardia dysrhythmia change here with this addition of the epi drip, just as a general reminder to set up an epinephrine drip, we want to run these as a 4-to-1 ratio. So for example, adding 1 milligram of 1 to 1,000 epinephrine into a 250 cc bag of normal saline would give us a 4-to-1 concentration, because that 1 milligram is 1,000 micrograms, and those 1,000 micrograms to the 250 cc's is a 4-to-1 ratio, and that will enable you to do a proper calculation, an easy calculation, especially those of you who have learned the clock, and you can use that to set up your drip. So going into the tachydysrhythmias, so Megan just concluded discussing the bradydysrhythmias. The differences in the tachydysrhythmias, to an extent, are similar in that the biggest change here is in formatting, right? Until now, the old protocol had really focused on the unstable dysrhythmias. Over here, we're splitting the unstable versus the stable. So in the unstable ventricular tachycardia with a pulse, we're going to follow exactly the same steps as we did in the past. Nothing here has actually changed. When it comes to stable, however, we have this new addition for 2022, where we can actually, under standing orders, administer either one of the following, either your amiodarone drip of 150 milligrams in 100 mLs of D5W over 10 minutes, which is your standard amiodarone drip, or your second option, which is lidocaine making a comeback into the protocols, of 1 milligram per kilogram with a maximum of 100 milligrams total IV over 2 minutes. Okay, so that would be a bolus. It's not a drip. It's being given over 2 minutes, but that really does mean over 2 minutes. So again, the changes here, just to summarize, are the formatting where the stable versus unstable was split off, the option to treat the stable patient without contacting online medical control, which you in the past had to make a phone call for, and the addition of a treatment for persistent stable ventricular tachycardia, which is coming up now in this slide, which reads as follows. For these patients that are in persistent VTAC with a pulse, following the administration of what you were able to do under standing orders, either that amiodarone drip or that lidocaine bolus, you can administer the other antidysrhythmic medications if available specifically, right? So if initially you have administered amiodarone and it didn't work, then you can still go ahead now and give the lidocaine, or vice versa. If you gave the lidocaine first, it did not work, they're refractory, you can still go ahead and switch to the other medication and give the amiodarone drip. Pediatric dysrhythmias. So this is a new protocol. In the past, this was kind of built into the other protocols. Pediatrics have a new focus now, treating them separately when it comes to certain protocols. So for dysrhythmias in a stable SVT, the big focus here is to perform vagal maneuvers before we go and run into actual treatment options with medication or otherwise. Additionally, just as in adult, after you have addressed the dysrhythmia, whether it is, in this case, tachycardia, or in other cases, possibly bradycardia, we're going to do a 12 lead after resolving the dysrhythmia to see what the underlying situation is and if there are any ST changes. So in this case, for stable, we're only going to do vagal maneuvers. If it is an unstable supraventricular tachycardia or a ventricular tachycardia, you're going to contact medical control for your treatment options. You're going to start an IV under standing orders here, and you are going to administer up to 20 mLs per kilogram of IV fluids with a maximum of 2 liters. That's obviously referring to the older children who are at the upper limit bordering adult. So here's how the protocol reads. So pediatric dysrhythmia, so you can see what it looks like in a snapshot. Here are all your standing orders from CFR through paramedic. And then your medical control options read as follows. For your unstable SVTs or your VTAC with a pulse, synchronized cardioversion at the energy settings you see over here, using the appropriately sized AED or monitor pads. For stable SVT, you have the option of giving an adenosine bolus, which is 0.1 milligrams per kilogram rapidly, followed by a crystalloid flush, watching the EKG for 1 to 2 minutes to see if there is or isn't cardioversion. And if SVT persists, to move to the 0.2 dose, the 0.2 milligram per kilogram dose rapidly with a maximum of 12 milligrams, followed by that crystalloid flush. And again, watching for 1 to 2 minutes to see that there is a change.